name is Elo Mapelu. I'm the chair of KENCO, which is a Kenya network of cancer organizations. I'm also the chair of Hands of Kenya, a member organization of KENCO, and a patient support group, which I've been working with for the last several years, working with the patients with leukemia and gastrointestinal tumor. And it's from that background of having worked for about 15 years with that group that I look forward to learning more today and interacting more on a topic that is very close to my heart, which is the role of primary health care providers in strengthening the cancer care continuum. And I'm saying this because I've seen and heard stories from a lot of patients that I work with. Currently, our organization has about 1,600 CML patients in the country, and a few others that are sister organizations from the region. And their stories begin from a particular point that seems uniform across, that before they actually started getting treatment, they will go round and round from one healthcare provider to another, trying to understand what they are suffering from and what their symptoms were. And I don't know about the other countries. Probably will learn from Dr. Laura later on what the experience is in Namibia. But in Kenya, the health-seeking behavior of many Kenyans, especially the ones in the rural areas, is an interesting one, because before someone actually gets into proper healthcare system, they will have tried so many other things. They will have visited their friends to get information about what their friends suffered from when they had similar symptoms, and they probably will be given some of the remainder medicines from their friends. Others will walk to the nearby chemist and have just some over-the-counter medicines prescribed to them just to alleviate the symptoms. By the time they get to healthcare system proper, it's probably several months to even a year before they are actually treated. And the sojourn doesn't end there, because even after they get into healthcare system proper at the primary level, they will do another round of several months before they actually get the proper diagnosis of their disease. Most of whom will end up getting to start their treatment very late, which contributes to a great deal in failure of treatment and increasing costs of treatment. And we know in this country, Dr. Laura will tell us about Namibia, up to 70% of cases that are presented for treatment, for cancer treatment, are actually late. According to the doctors, they could have been treated, could have been identified earlier, they're properly diagnosed earlier, and they started on treatment earlier, but they come in late. The treatment ends up being very expensive, and sometimes, actually most of the time, not very satisfactory. So today, probably then, our focus will be to see what role primary healthcare workers play, because we know that to reduce these numbers from 70% to something that is manageable, we will want to see the input of primary healthcare practitioners in trying to help diagnose early and start treatment early. And why I say this topic is very close to me is because as KENCO, we decided that this year, most of activities, actually the main activity for us this year will be to try and identify what gaps there are as far as awareness is concerned, information is concerned, among the primary healthcare workers, to try and bring them to a level that they are able to be more effective in offering their service and in identifying cases that could actually benefit from early treatment, early diagnosis and treatment for cancer. So I'm just saying that as an introduction. I'm sure there's a whole lot more that we can discuss on that. But I don't want to take it all away. I will be inviting Dr. Laura to speak to us. But before then, I just want to do the usual housekeeping. First of all, make sure that you're muted. Before, I mean, if you're not speaking, just so that we may be able to avoid back and forth and making our session smoother. And if possible, let us see you. Switch on your video. It makes it more interactive. If you can, just when you're speaking, you can switch on your video so they can see you and have a more close interaction. Use the chats at any time to introduce yourself and ask a question or make any comment. I'll be taking note of all the questions. We're going to have an interesting conversation later after the presenter. So make sure all your questions or comments are put down there. And if you need to enable subtitles on your screen, you can go ahead and do that. And also to let you know that these sessions are recorded, and the recording will be available. Charles will send us link where we can be able to access the recording. So we want to dive deep. I know we were expecting to see Dr. Mary Rose Giatas from Tanzania. She hasn't yet joined us. If she does, then we'll be able to have her speak to us and give us a didactic presentation later on. But right now, I want us to give this time to Dr. Laura Muzingwani. Dr. Muzingwani has been working in both clinical and public health aspects of cervical cancer prevention for the past 8 years. Her interests include implementing equitable access to high-quality preventative sexual and reproductive health care services for adolescents and women. She obtained a medical degree from the University of Zimbabwe and has worked in the Zimbabwe public health sector for 4 years, where she participated in the introduction of see and treat cervical cancer prevention services. She has also worked with the Humanitarian Red Cross and Red Crescent Society in Zimbabwe to provide cervical cancer prevention services to the underprivileged. Currently, Dr. Muzingwani works as a cervical cancer prevention lead physician at iTech Namibia, where she leads a team of cervical cancer prevention quality managers and provides technical assistance to the Namibian Ministry of Health and Social Services to design and implement comprehensive cervical cancer prevention program. In her current role, she also provides training and ongoing mentoring support to various healthcare workers on cervical cancer screening and treatment of precancerous lesions using ablative and LLETZ surgical procedure. She currently serves at the World Health Organization Cervical Cancer Elimination and Guideline Review Committee, and locally is a member of the Namibian Cervical Cancer Prevention and Family Planning Technical Working Groups. So, ladies and gentlemen, excited to introduce Dr. Muzingwani and invite her to give us a presentation. Welcome, Dr. Laura.
Thank you very much, Elo, and good afternoon to everyone. Thank you for the opportunity to come and present. I was hoping that Dr. Peters would have given the didactic, and then this would have tied in with my presentation. So I'm just going to share a case, a couple of cases that we have encountered here in Namibia, which is just going to demonstrate the important role of primary health care workers in terms of providing cervical cancer prevention services. Can you kindly allow me to share my screen?
You can go ahead and share.
All right, great. All right, let's confirm you can see my screen.
Yes, we can see.
Okay, thank you.
That's it
Great.
clearly.
Okay. So we're looking at the battlefront where really our primary healthcare workers are in terms of providing the services. So I'll present to you a case of a 26-year-old non-HIV positive woman who was para 2 at the time of presentation, and she acquired HIV through vertical transmission. She was enrolled in HIV care in 2005 at the age of 12. She started ART, and she started on AZT3TC NVP as the initial regimen. This was the then usual regimen that you would start your clients on. Then in 2006, she had full disclosure and cotrimoxazole prophylaxis given. In 2019, she also successfully completed her IPT, this is prophylaxis for TB. Then in 2010, she switched to the TDF AZT 3TC lopinavir based regimen, which was a second line due to the high viral load that she had. And in 2016, lopinavir was substituted by atazanavir. Then 8 years later, in April 2018, she was then, after being on second line for the past 8 years, is still experiencing persistent high viral load. Resistance test was done, and client was actually noted to be resistant to all NNRTIs, NRTIs, and PIs except for darunavir. Then when you look at the 3-year viral load profile for this client, in 22 April 2016, she had a viral load of 221,183, log 5.34. In 2016, you see we consistently had a very high viral load, and it was partially suppressed, but not really achieving the actual suppression by April 2018. So in May 2018, after the resistance testing was done, she was put on a holding regimen of 3TC only as recommended whilst pending a drug resistance committee. So in Namibia, we have got a drug resistance committee composed of HIV clinical care experts who actually review these clients that will be having very high viral load and also having resistance to most of the ART drugs. Then in July 2018, she was switched to third line, TDF3TC, darunavir and raltegravir. Then in 2019, her viral load actually came down to 218 copies per mil, and the occurring raltegravir resistance substituted to DTG on 8 February 2019. Then April 2019, viral load was suppressed to actually less than 40 copies per mil. And this is a battle that was won, because the battle has been to really suppress the viral load for this woman who had quite a significant resistance to ART. The story then continues. Then on the other side, she had never had any pap smear done during this entire battle of more than 8 years to actually suppress a viral load. She presented with a vague history of spotting and PV bleeding early 2018. Healthcare workers diagnosed side effects of contraceptives as the diagnosis, and no VE was actually done, and no medication was given to this patient. Then in 2018, in 2018, the patient fell pregnant and delivered through cesarean section, and had quite the full package of prevention of mother-to-child transmission care. Then 6 weeks postnatal, she actually managed to attend. Her baby was tested, and she was not breastfed, and the DNA PCR for the child was negative. This was another battle more. However, a few months down, 1 year later, in 2019, the client came for her initial VIA screening, which was done. And this was this actually showed the client was suspicious of cancer. And ultimately, this is a battle lost for this woman. So we see there are multiple missed opportunities that actually it transpired for this woman. There was no pap smear screening done. Then in diagnosis was just put a side effect of contraceptives. Then throughout the PMTCT, ANC care, no indication and no screening for cervical cancer was done, even at the 6 weeks post-delivery. It's only when the patient then presented symptomatically that it was now in 2019 that she was actually diagnosed as being suspicious of cancer. In Namibia, currently FIA is the main screening method that is used. We also use a pap smear. So although there was the huge battle to suppress the viral load, now this patient is actually diagnosed as having cervical cancer, and this becomes then a battle that is lost. So histology of the cervical mass showed a well-differentiated squamous cell carcinoma. And then it may also emerge that her elder sister had died at the age of 36 from cervical cancer, which was diagnosed late. And for herself, clinically, she was at this stage 3B. And from this point on, we refer her to Oncology Center for Management. As Elo had shared before, like most African countries, patients are not going to stick to only to the conventional or medicine, but they will also try other methods. So she actually defaulted oncology follow-up, and unfortunately, the patient died in July 2021 due to advanced cervical cancer-related complications. So antiretroviral therapy is generally given in primary healthcare settings in Namibia, and secondary care and tertiary care usually come after if there's any other complication which might have developed. So let's look at another case again, just also to illustrate how things can also work in a primary care setting. So we have a 56-year-old woman who was unknown HIV status and presented to a primary healthcare clinic complaining of ringworm of both hands. And she was HIV unknown. She was offered PITC and actually turned out to be HIV positive. On that same day, because we also provide test and treat, she was enrolled in HIV care. Clinically, she was stage 2. Functionally, weight BMI was 29. She was para 3, and baseline assessment, creatinine, and the usual things. Everything was normal. She was started on ART as well as given IPT and cotrimoxazole as well. 1 month ART follow-up, she was offered cervical cancer screening during the cervical cancer campaign. And she unfortunately, she was also symptomatic and accepted cervical cancer screening, but decided that she was going to do it at the next pill pickup date after being after having a discussion with the ministry via trainers. So this was also the first time for this patient to be actually screened at the age of 56 years of age. Then the 1 month ART follow-up, she got her cervical cancer screening done and used pap smear because she was postmenopausal. Pelvic exam thought that was suspicious of cancer, and she was referred for biopsy. The cervical biopsy done showed invasive carcinoma encompassing blood vessels, and then she was ultimately referred to gynecological care. So looking at these two cases in terms of comprehensive care at a primary health care site, cervical cancer screening is one of the preventative core services that should be offered at in any primary care setting. However, for case 1, it took 6 encounters at primary health care level before cervical cancer screening was offered. And for the second case, it was on the 3rd visit that the client then received this essential screening services. In case 2, presentation was non-cervical cancer related. She presented because she had ringworm, essentially, and because she had an HIV test, which is offered as part of the comprehensive primary care package. This then actually put as a high priority case to receive cervical cancer screening. However, there was late presentation as both cases were symptomatic at presentation, and there was also an element of mismanagement as side effects of contraception. This is also something that we are seeing in primary healthcare workers, where there's this lumped or grouped diagnosis if the patient is on any progesterone-related contraception, the first thing is PV bleeding is just side effect of contraception. In 26 and 56, you can also see early onset and development of vertical transmission of the 26-year-old versus the one with horizontal transmission. So this got us thinking, and just to spare a moment and think, what exactly do we want to achieve for people or women living with HIV? Research has shown that U is equals to U. If you are virally suppressed, undetectable, then it's untransmissible. That's one big battle that we have won in terms of fighting the HIV pandemic. But is this all that we need? Now, looking at the cases that I just shared, there is a need for comprehensive care in terms of people living with HIV, from both communicable and non-communicable diseases that encompass the whole care continuum for the different types of groups of people that we find living with HIV.
How are you?
All right. So just as something to discuss, just to point the essential role that primary healthcare workers have is they are at the forefront and entry level of the healthcare system, as this is their first encounter and really where you end up in the system depending on how soon the client would have presented. And when you look at primary prevention for cervical cancer, really this offered at the primary care, the entry point before the client even becomes symptomatic. However, you find that the health-seeking behavior is often related to beliefs and is influenced by so many other things within the society, which actually delays the presentation to the primary healthcare workers. And then primary healthcare workers also need training and support to implement comprehensive prevention packages. So while there's very strong efforts in terms of combating HIV within the country, we are still building up the system for cervical cancer prevention to try and get it to the same level. And we also know that we have to involve the primary healthcare worker and provide essential training so that they can be able to implement these services. Then full integration of cancer prevention programs into existing primary healthcare structures is also very crucial. As you can see, an array of services are available at the primary healthcare setting, but without proper integration and having siloed approach results in one of the elements actually being missed. And this is something that we do not really want to have happening. Then refresher training of healthcare workers on implementation of preventive activities is also crucial for successful cancer prevention, because even though they would have undergone the usual run-of-the-mill training, there's new developments, new advancements that are coming in terms of cancer prevention as a whole, and there's a need to make sure that the primary healthcare workers are actually made aware of this. Thank you very much for this opportunity. I'm actually out on outreach. We are trying to provide services as close to the clients as possible, and actually trying to see how this can also boost the primary healthcare system. Thank you very much for this opportunity. Over to you, Elo.
Thank you, Dr. Laura. Thank you, Dr. Laura, for that presentation. It is clear from Dr. Laura's presentation that there are a number of missed opportunities which integrate the services at primary health, primary level in all health setup, and it's also important to know the big role there is to ensuring proper training and retraining of primary healthcare workers in all areas to be able to effectively offer the services in their local setups. So thank you, Dr. Laura, for that presentation. I don't know if we haven't, we have got Dr. Gatas already. Is she on? Would you know, Charles?
She's next.
Dr. Mary Ross Gatas. Has she joined us already?
No,
Okay.
she is not.
Oh, she hasn't. Okay. All right. That being the case, then I'd like to invite us to share our thoughts, ask our questions, and help us carry on with this conversation going forward from Dr. Laura's presentation. I guess since we are not very many of us, you can, if you have a question, you can either raise your hand or you can just unmute and ask it. I will be able to see you. And as you're preparing to do that, I just also realized from Dr. Laura's presentation that most of our cultures are similar. The health-seeking behavior of most of us is fairly very similar, and the same path the patient takes before they are even diagnosed is similar across the continent. I don't know about other jurisdictions, but across Africa, it's fairly similar. A lot of missed opportunities that characterizes the agony that patients have to go through to get the highest quality of care that is promised by our governments. I know there are a lot of efforts that have been done in trying to especially help the cancer patients navigate through the cancer care system. But one of our biggest challenges is actually the journey they take prior to starting this treatment proper, the journey they take as they try all other opportunities that they have to try and address their various symptoms, because before they are diagnosed, they're just dealing with symptoms. And that journey, which is very, sometimes can be very long, if it is not properly done, usually will lead to what I mentioned earlier, treatment failure and probably late presentation, which also leads to a very high cost of treatment. And it is that journey, the even before diagnosis, that one, the wilderness, I don't know how best to call it, that really needs some serious amount of addressing, because we've done in our small way, try to create awareness among the public and try to make them know that what to expect when they have some some kind of symptoms, and what to even ask when they present themselves to the hospital. That one we've tried to some extent. I'm sure it's still work in progress, but there's still a whole lot more that needs to be done to try and get people out of this wilderness. And part of it is to help the healthcare workers, the ones that they get in touch with at first, to be able to have a suspicion index that will help them be able to direct them and navigate the patients correctly. So I believe the place of the primary healthcare workers in ensuring and in strengthening the cancer care continuum is very central and very key, and it is actually what will determine the outcomes in most cases. So I would like to invite you, every one of us who's here today, to share their thoughts on this and carry on this conversation in the next few minutes.
Yeah, I'm not sure if you can see Dr. Anna has her hand raised.
But I'm not able to see from here. Oh yeah, sure. Dr. Anna Yakabao. Sorry, I hadn't seen your hand earlier.
No, thank you very much. Good afternoon to everyone. Yeah,
Yes.
it's been a very interesting presentation, which resonates with a lot of problems that we face in our environments. I mean, talking from my own country point of view, I mean, cancer literacy is very, very low amongst even healthcare workers, such that I think we really need to address even fundamentals such as the pre-service curriculum, because yes, we can actually educate healthcare workers and re-educate them on job, but we need to lobby such that we can actually get the curriculum being cancer sensitive, so that at least we get more people being educated in cancer care. And that's my input.
And I agree with you absolutely, Dr. Yakabao. From which country are you, Anna?
Oh, I am Zimbabwean. Thank you very much.
Oh, Zimbabwe.
Yeah.
Oh, great,
Mhm.
great. Yeah, I'm sure it's similar, like I said, it's similar across. You're right. Pre-service training, very important. And of course, a little bit of navigation. We have to teach them about navigation, pre-treatment, and even throughout the treatment continuum. Thank you, Dr. Anna. Dr. Laura?
Thanks, Elo. Thanks to Nyakabao for sharing that. Also from Zimbabwe originally. So I just also got me thinking that besides just targeting the primary healthcare workers, there's also a need to actually also target educating the clients and demystify some of the myths associated with cancer treatment, because you'll find that once someone has a diagnosis, they tend, like you are saying, to seek other methods and actually shun the conventional medical way, because they see it as something that will actually worsen the cancer. And these are some of the myths that they have in terms of the healthcare seeking behavior. So there is also a need to address that gap for really providing client education, that they can also try and improve their health-seeking behavior. The other thing is, most of the time, when nothing is wrong, I'm feeling okay, we don't usually tend to visit healthcare facilities for screening services. Most of the time, it's you go to a healthcare facility if something is wrong or if there's some pain somewhere. So it's all this lack of information and knowledge that there is something that can be done before you actually develop the actual disease. Thanks. That's what I just wanted to share.
Thank you. Thank you. Yeah, you cannot overemphasize the need for awareness, making sure that we've passed across the message across to everybody. There's an interesting reaction I got from a colleague of mine. Usually, when you're presented with a case and you suspect this could be cancer, it is very difficult to even want to direct the patient to seek treatment for cancer, because one of the reasons, of course, is because cancer treatment is very expensive, and immediately someone hears about cancer and the fact that they might actually be suffering from cancer, the first thing that comes to their mind is what am I going to sell? How am I going to raise the funds for treatment? And immediately, you're starting losing the battle there and then. Part of what needs to actually be passed around is information to the health providers in primary setting, and even to the public, especially in a setup like ours, where we have some good work being done by the national insurer to help treat cancer patients, to just inform them that though it may be cancer, there is hope, and there is a way to actually get you treated without having to sell your arm and leg. It's probably just how we package this information, and the wholesomeness of the information that we pass across that will help beat some of these challenges that we have. Also, the aspect of stigma, like has been mentioned, needs also to be addressed, and of course, this is also a question of what kind of information, how do we package the information, based, of course, on the background of the, or the public, to have that intelligence, know how to package this information and help inform the public about it. So thank you so much again, Dr. Laura, for that. I hope there's no one raising their hand and I'm missing it. I'm trying to really scan through
No,
and make
you're all
sure that
set.
I'm not. Yeah, okay. I'd like to know how it is in other countries also. Charles, are you making a contribution? Charles Mwangi? If you are, you're not very clear. Okay. So I'd like to learn also how is the situation in other countries also, even outside Africa. How deep is the knowledge? How wide is the knowledge on cancer care? We just like to compare those and see how things are down there. At least here in this country, we know up to 70% of cases that are diagnosed are actually diagnosed late. That's an indicator of not very good information going down to the roots. I don't know how the cases are outside Africa. Mishka, you probably have an idea.
Sorry, it would be great to hear from others, actually. Well, Elo, sorry, I don't have a, not to respond to your question, but I do have a question if others don't have other responses to yours.
Great, go ahead, Kisha.
So I appreciate the comments that are made, especially around concerted efforts for training, both at the healthcare worker level, at the client education level, as well as integrating services for patients. And I'm interested to know what, Laura, from your experience and others, what you would recommend as an immediate next step or first step in ensuring, like, what would be that next step to take in your setting to ensure that could happen? Obviously, there are guidelines and policies and all of that. So just curious to see, what you think would be an immediate next step, or if there are policies that are in place and not being implemented, what your thoughts are, how to facilitate that to happen more effectively. Over.
Thank you, Misha. I'm sure we'd like to also know how other experiences are. In our setup, there are policies. We had some discussion some time ago during the National Cancer Institute summit sometime in February, just around the World Cancer Day. And the conversation that was going on around there was pointing to the fact that this country is rich in policies, and especially on the beat on training healthcare workers. There is a lot of work that has been put into developing policy. We just lack in being able to make use of those tools that we've developed to actually make the work possible. Some of what we are thinking, and the thinking of KEMCO is try to unlock some of those provisions, work with the government in trying to modernize the kind of training curriculum that there is, and try to inform it with the latest information that there is, trying actually effectively to try and meet the demand that is there. Is like doing a review of what is there and seeing how best it fits today's today's needs, because we have it, we have the write-up, we have the policy, but we are not able to fully utilize it. For example, there are a lot of new technological advances that could actually help in making sure that this training need is met, but they are not you know, they are not supported by any policy framework which as currently exists. So there is need to relook that and try to you know, improve and adjust the policies to accommodate today's real need. So in our country, I know the work is actually to try and make the structures that are there actually work and responsive to today's needs. I don't know about other places, but I know that's the work we are doing, and that's the work we as KEMCO have planned to do, work very closely with all the stakeholders and try to meet that particular need. I'd like to hear what the case is in Namibia, Dr. Laura.
Hello. Similarly, we do have policies in place, but it's about the implementation that is a challenge in terms of the resources to providing this comprehensive care package and also to providing training. We are in the process of trying to actually boost the system and trying to seek other ways to provide training for healthcare workers who are now at the post-service. And for the pre-service, we are now liaising with the training institutions so that they integrate cervical cancer prevention specific activities to actually be provided and for the healthcare workers to receive the training before they actually graduate and are providing services. Then for those who are already in service, we are also in the process of building an online platform to make these trainings available. But then there are also other challenges that these online trainings, they're difficult to access if you are working from a remote area where you've got limited internet access. So these are some of the things that we are trying to see how best to deliver in terms of empowering the primary healthcare worker so that they're able to deliver efficient services. The other thing is some may have the knowledge, a few may have the knowledge, but it's about now the tools to actually implement and provide the treatment, say, for the precancerous lesions that are detected. So this is something that also the ministry is working on, trying to boost the procurement of equipment to provide near point of care services for women so that they don't have to be referred to the next level, and this actually becomes a lot of work on the primary health caregiver in terms of trying to facilitate to have this patient be managed for something which could have actually been handled at this primary level, have to go to the next level as well. I would say these are the challenges in terms of getting resources, but policies are in place. We are also in the process of updating the National Cancer Control Plan for Namibia, which would then include not just the cancer management for cervical cancer, but the whole cutting across the board. The challenge is, like you're saying, it's very expensive to treat and to provide care for confirmed cancer cases. And this tends to be sort of the limitation in terms of the actual final care for clients. So this has been the experience here in Namibia. Thank you.
Thank you. Thank you. Do healthcare workers there have existing framework to offer continuing professional development and CMEs? Something probably similar to what we have here. There are all regulatory authorities that regulate these healthcare professionals usually will demand that they have a certain number of points before they are licensed to, to practice. Do you have such a such a framework? Probably that will be one of the avenues that we can be able to do the post training trainings.
Thanks, Elo. Yes, we do have, there is a National Health Training Center that actually provides a platform for regular CPD-related activities. So this is actually the platform that is actually currently being used to develop an online hub, which would then make the trainings now available without having to have people come and be in a conference for a certain number of time period before they can actually get this training. We also have an eco platform, although mainly it's HIV management related activities, which runs on a weekly basis, which healthcare workers from across the country can actually log on and just listen into the activity. And it is accredited by the HPCNA and has got CPD points that are also given there. So that's another platform that we also use from time to time. Thank you.
Okay. No, thank you. Thank you very much. Pamela, I can see your hand.
Thank you, Ella. And I just want to contribute, especially when it comes to the capacity building for the frontline fighters. Those are the primary healthcare providers. Currently, there are preceptorship courses that people can undertake when they're within their places of work, because in most cases, you realize that people cannot go for training because of shortages or low staff in a certain facility. So those preceptorships are also a booster to capacity in order to increase the awareness among the healthcare providers, because once the healthcare providers are well empowered, they can be able to pick the early signs. Because sometimes you can find that maybe awareness is created, advocacy is done, community education is done, and then when the clients present themselves to the health facility, and somebody is not maybe able to take care of them well, then still we end up with late diagnosis. We also have the on-job trainings whereby maybe we do mentorship and follow up for those who have been trained, and also support supervisions. And this is also another way of boosting capacity or building capacity. And then from the NCCP website, we have the M-Saratani app, which has information about cancer, all cancers, and it's also another source of information. Also through International Cancer Institute, we carry out short courses for the staff, which are CPD accredited, and also the tumor boards, which are CPD accredited, and these also are sources whereby the healthcare provider get to learn. Challenges, as we have said, you may find that somebody has been diagnosed, maybe identifies the signs early enough, but because of the level of poverty and lack of insurances that we have around, one may not be able to present themselves and get treated well, because these treatments are not free. Screening is free, diagnostic is not free, staging is not free, initiation of treatment is not free. I don't know what happens in other countries. Maybe other people have different experiences, but these are the challenges which we are facing in Kenya as a country, and which we are all trying to combine forces to see how well we can be able to articulate these cases and control, especially cervical cancer at a lower level. Thank you.
Thank you, Pamela, for that. Just a quick one for you. Is there any way to ensure that the health workers actually take up these courses that are available to them through the various channels that you've mentioned? Is there any way to ensure? Because, like you said, they are there, and some people will choose not to. If it is not mandatory, and we will still have that gap. Is there a way that that can be made mandatory for for every healthcare worker to participate in those training?
Okay, there is no policy that makes it mandatory, but people who work in a certain area should have some qualifications to make them be able to manage their clients to the expected outcomes. So what makes staff or professionals really to get into these courses is because of the renewal of their practice licenses, which of course, if they don't have CPD points, they cannot be renewed. And if they don't attend these courses, some of them, the cancer-related or other disease-related courses, they are not able to attend these CPDs. So this is one cause. And then also, what happens is that the National Cancer Institute, they also do visitation to the cancer treatment facilities to check on the staff who are there and to what level of treatments have they attained, and if they have not attained that level, what is the facility doing to ensure that those who are working there have attained those qualifications. Then I've also talked on mentorship and on-job. We have mentors or master trainers or mentors who go around and check on how people are performing on what they have done. And in case somebody has not done some course, especially those that relates to cancer screening, what can we do to help? And there are some other stakeholders who come together to help in training of the healthcare providers at the primary levels.
Ah, great. That's really good. Are these training free? Are they available to the healthcare workers free of charge, or they'll be required to pay something to access?
M-Saratani app, the short courses on M-Saratani app are free. And also this preceptorship, it also depends on where you are doing the preceptorship. But I can talk about the International Cancer Institute preceptorships for the facilities of the counties that we are having the MOU with and working with. The courses are free for them, but for those whom we do not have MOU with them, there is some little fee that is paid, and that is up to, is it $200? But when somebody is interested and is not able to pay, we have also scholarships for that.
Great. That's very good information to know. I wish there was a way we can make sure this information is available across, because I'm sure the uptake is not as much as we should be comfortable with. Probably then the work that we need to do is to make sure that we create that awareness among the healthcare communities, to make sure that they know that such trainings exist and where they can be able to get the trainings. Emma?
Thank you, Maperu, and good afternoon, everyone. I want to talk about what Pamela has talked about, the MOH, the M-Saratani and the MOH Virtual Academy. This is what the National Cancer Control Program is actually implementing right now. There is a virtual module of training, which is it's braided because service providers are recruited. They enroll in the virtual class. They do learning, and then for certification, they have to complete with clinical training. So they have 3 days of physical training. And there are some already enlisted in 22 counties. This is already ongoing. Thank you.
That's good to know. Thank you so much, Emma, for that information.
Maybe just to ask, what happens in other countries, which are, especially the ones which are represented here? How do they go about capacity building? Because we cannot get everyone going to class and get to learn, because facilities also have to be run. How do they conduct their trainings?
Yeah. Good question. Yes, go ahead.
I think with the first invitation of rollout, I think there will be communication on how then people can engage on that forum, and it is open for partners to use. So there should be communication from the national team.
You're talking about the M-Saratani, right?
MOH Virtual Academy, the cervical cancer module, or the cancer module, rather.
All right, so it has much more than just cervical cancer, I guess.
It has several modules.
Great.
It was actually to reflect on all the cancers.
Okay.
There are several modules.
Oh, that's great. That's great. Pamela has asked a good question. What is the experience in other countries? Do you have that kind of arrangement that we have here? How can we improve ours? And as we are waiting to get to learn that, there's a question here for Pamela. Paul Monique is asking, could Madam Were share the opportunities of training by NCI/NCCP here? Madam Were, probably then to answer Paul and to also help the rest of us is where do we get this information? Is it on the MOH website? Where can we get this information? On the available training opportunities.
For the cancer module, you just download the M-Saratani from the App Store. And once you download that app and you register, it will guide you on how to log into the short courses.
Okay, all right, thank you.
And for ICI, well, you can check from the website, or maybe I can give my email address so that we can share, we can exchange information.
That will really help. Please share your email address. I'm sure even on follow-up questions that will probably not be asked here, someone will be able to follow up and ask. Thank you. Do you have any other question that we can interact with before we call it a day? Any other contribution? Any other issue that you want us to raise? So Pamela and Mishka have shared the necessary contacts. Pamela's email address is there, and Mishka shared with us the ICI website where you can get all this information and trainings available, which are offered by ICI. All right, thank you. I think in absence of questions, Charles, probably you take it over from here.
So thank you very much, Pelu. Thanks to our speakers, our participants for attending this session and being active. We are grateful for your contribution to this. So as Mapelu said, we are going to share the recording and Dr. Lola's presentation on this camp. So look out for that. Our next session will be held on April 20th. And we are going to be looking on a topic on health information systems. We are going to share the agenda with more details and the specific topic the coming weeks. So again, look out for that. If you're not on this camp, you can reach out to us or to Mishka, and you'll be able to be included in the distribution list. So I think that is all for now. You have a good time, and we look forward to see you in the future sessions. Thank you so much.
Thank you. Thank you so much. Thank you, everybody, for participating. See you next time.
Everyone.
Asante.
Thank you.